Good morning everyone. I am Dr. Garima, reader from the Department of Oral and Maxillofacial Pathology. My topic is benign epithelial neoplasms of oral cavity. What is neoplasia? Willis define neoplasia as an abnormal mass of tissue, the growth of which exceeds that of normal tissue and persists in the same excessive manner after the cessation of stimuli which evoked the change. So first I'll be dealing with papilloma. It's the most common benign epithelial neoplasm it is called papilloma because it is an exophytic growth made of numerous finger-like projections. The growth has a cauliflower-like appearance and that is why it is known as verrucous type. Skin counterpart of this lesion is verruca vulgaris or the wart, which is associated with HPV virus. Multiple papillomas are seen in focal dermal hypoplasia, which is also known as Cordon syndrome, which is a marker for breast cancer. Clinical features of this lesion, as it is seen in the picture, it can be seen in any age and person of both sexes. Common sites are tongue, as it is there, lips, buccal mucosa, hard and soft palate. It develops as a slow growing, painless growth. It is whitish in color and firm in consistency. It's well circumscribed, pedunculated growth. Coming to histology, numerous thin finger-like projections or extensions are seen which project towards the surface. Each projection is covered with normal appearing stratified squamous epithelium. The covering epithelium may show hyperkeratosis or acanthosis. Each projection has a central core of connective tissue with blood vessels and few inflammatory cells. The treatment and prognosis: excision including base of the mucosa into which pedicle inserts, and it is a rare recurrence if the excision is done properly. Coming to the second lesion, which is keratoacanthoma, clinically and histologically it resembles a lesion of squamous cell carcinoma. The tumor starts as a small, firm nodule which grows to its full size over 4 to 8 weeks. It remains in the same state for next 4 to 8 weeks and then it regresses spontaneously over next 6 to 8 weeks. And due to this unusual clinical course, it is also called as self-healing carcinoma. Clinical features: most commonly it is seen in 50 to 70 years of person. Males and females ratio is 2:1. It is very rare in intraoral site and mostly it is seen on skin surface of lips, cheeks, nose and hands. The vermilion border of the lip is commonly involved. The lesion is treated by complete surgical excision. Some cases they do not regress spontaneously and some they leave a residual scar on healing. See, this is the lesion. Most commonly it is seen on vermilion border of the lip. It looks like sometimes squamous cell carcinoma also. Coming to the histopathology, hyperplastic squamous epithelium is seen growing into underlying connective tissue in this way. The surface is covered by thickened layer of parakeratin or orthokeratin with central plugging. Epithelium, it does not show atypia, but dysplastic features may be present. Most characteristic feature at the margins where normal adjacent epithelium elevated towards the central portion of crater. This term SCC or squamous cell carcinoma, keratoacanthoma, has been introduced for otherwise classic keratoacanthoma that reveals are squamous cells with atypical mitotic figures, hyperchromatic nuclei and loss of polarity to some degrees. Treatment, of course, surgical excision. Spontaneous regression occur in every case. Prognosis is excellent following surgical excision, and recurrent tumors, they acquire more aggressive therapy. Now coming to nevus. Third lesion is nevus. Pigmented cellular nevus. A nevus is a congenital developmental tumor-like malformation of skin or mucous membrane. It refers to lesions of skin or mucous membrane containing melanin pigment. Oral nevi. The other name of oral nevi, oral melanocytic nevus, nevocellular nevus, mole, mucosal melanocytic nevi. It's a type of hamartoma and it is due to developmental malformation. Benign proliferation of nevus cells in epithelium or connective tissue. The first case was reported by Ackerman and Field in 1943. So, this type of oral nevi, we can see it's there in oral cavity on the palatal side, and again this type of lesion can be seen. These nevus cells, they are melanocytes which are neuroectodermal in origin. These melanocytes are normally present between the basal cells of skin or mucous membrane. Nevi are present at birth, or development of nevi can be seen soon after birth. They may develop on any part of the body including oral mucosa. These nevi may be congenital or acquired. Congenital nevi are present at the time of birth. They gradually change from flat, pale macules to elevated verrucous hairy lesions. Intraoral congenital nevi are very rare. Then classification of acquired, mostly classified as junctional nevi, compound nevi or intradermal nevi. In junctional nevi, nevus cells are seen at the basal layer. In compound nevi, these nevus cells are seen in epidermis and dermis, and in intradermal nevi, the nests are seen in entire dermis. Most commonly, intramucosal type accounts for more than 1/2 of all oral nevi. Second most common type is blue nevus, which is common in mouth than in skin. Clinical features: congenital nevi, small one should be greater than 1 centimeter, and the other type is garment nevi. Garment nevi, why it is called a garment nevi? Because it is large in size and it appears as if the person is wearing a cloth, and it is usually greater than 10 centimeters of size. This type occurs in 1 to 2.5% neonates. With the passage of time, it may change from flat, pale, tan macule to elevated verrucous hairy lesions. Intraoral nevi may be seen on the hard palate, as I have already shown in the picture, buccal mucosa, lip or gingiva. Most are raised pigmented lesions, and 20% of lesions may be flat. Rarely lesions are not pigmented and appear as small growths of normal color. Most common type is intramucosal or intradermal type of nevi. Histologically, nevus cells are derived from neural crest cells, and their relation with melanocytes remain uncertain. Nevus cells, they are oval, round, spindle shaped, having pale cytoplasm, granules of melanin in cytoplasm. Melanosomes are not transformed to adjacent keratinocytes. These are grouped in sheets, cords, and these are known as nests. Multinucleated giant nevus cells are also seen. Now coming to the congenital type of nevi, as it is shown in the picture, nevus cells, they extend to deeper levels of dermis with infiltration of cells between collagen bundles, as it is shown here in the connective tissue. It is seen intermingled with neurovascular bundles in reticular dermis and surrounding normal adnexal skin structures. Now coming to pigmented cellular nevus, acquired nevi, they appear in 8th month of life and increase in size and number till the 3rd decade. With increasing age, the number of nevi may decrease. Now types of acquired nevi, as I have told before, junctional nevus, clinically similar to the common mole. Differentiation is very important because these lesions show a very high rate of malignant transformation to a malignant melanoma. The nevus cells are seen in the basal layer of epithelium. Compound nevus cells are seen in the epidermis and dermis. Intradermal nevus, which is also called as common mole, small, smooth or elevated pigmented area on skin or mucosa, usually associated with the hair on the surface. Nevus cells in this type intradermal are usually seen in the dermis layer only. Junctional nevus, zone of demarcation is absent in this type of junctional nevus. Nevus cells, they contact and blend into the surface epithelium as it is shown here in the picture. Epithelium is quite thin, irregular, showing cells across junction and growing down into the connective tissue as it is shown here, called atrophying or dropping off effect. This dropping off effect is very important. This undergoes malignant transformation into melanoma. Types of acquired nevi, blue nevus. It's a rare benign pigmented lesion that on microscopy shows melanocytes within the middle and upper part of dermis. Most common, blue nevus. Cellular blue nevus is other name, or epithelioid blue nevus, which is also known as Spitz nevus. These are of two types. Common type, common blue nevus, firstly described in 1906. It has long elongated melanocytes which are arranged parallel to epidermis in middle and lower 1/3. Melanocytes, these are packed with melanin, obscure the nucleus, granules extend to dendrites. Cellular nevus, first described as a variant of melanoma and later it was classified as a variant of blue nevus. It has a large, round or spindle shaped with pale vacuolated cytoplasm, which is a very important feature. In this, these cells are arranged in alveolar pattern. So the blue color is caused by the pigment being deeper in the skin than in ordinary nevi. Spitz nevus, composed of pleomorphic cells which are of three types: spindle, oval or epithelioid cells with both mononuclear and multinucleated giant cells, arranged well circumscribed sheets, and there is generally considerable junctional activity. Oral manifestations seen in patients above 40 years of age, seen in all races and more commonly seen in whites and women. Hard palate is the most common location, followed by buccal mucosa, vermilion border of lip, labial mucosa, gingiva, tongue and floor of the mouth. It's asymptomatic and found in incidental finding and often mistaken for melanocytic macule, amalgam tattoos, physiologic ethnic pigmentation. Differential diagnosis: amalgam tattoo, hemangioma, smoker's melanosis or malignant melanoma. So these are the lesions which you can see: malignant melanoma, amalgam tattoo. Treatment and prognosis: the acquired cellular nevus is so common that surgical excision of all these lesions are not possible. If surgical excision is advised, then lesion should show sudden increase in size or change in color or ulcerations of the surface. Lesion in areas subject to constant friction like the collar area on the belt line area. Intraoral nevi, as these are subject to constant chronic irritation due to mastication, toothbrushing, etc., surgical excision is advised. Thank you.